Good evening and a very warm welcome to all the doctors who have joined us this evening for another episode of NEFFRON, an expert-curated lecture series for physicians dealing with kidney disorders. NEFFRON is an educational initiative by Saffron Formulations which aims to address the knowledge resource gap that exists in treating the kidney diseases. And the objective behind this particular program is to involve the experts in the field of nephrology to disseminate their knowledge and expertise in treating the kidney disorders. Without much delay, I would like to welcome and introduce our speaker and clinical expert for today's session, Dr. Sonal Dalal. Dr. Sonal Dalal is a senior consultant nephrologist and a transplant physician and director of Gujarat Kidney Foundation, Ahmedabad. She has more than 25 years of rich experience in the field of nephrology and has more than 20 international and national publications under her name. She is also a secretary of Nephrology Forum of Ahmedabad, Gujarat. Now, I would like to welcome and hand over the session to Dr. Sonal Dalal to address the audience on the topic of hyperuricemia, what, when, how to address. Over to you, ma'am.
Thank you. Thank you, Saffron, for giving me this opportunity to interact with the physicians regarding a very important topic, that is hyperuricemia. There are so many do's and don'ts in hyperuricemia, and there are so many new drugs which are available. There are so many newer concepts which are coming up in the treatment of hyperuricemia, and that's why I think it is a very important topic that we should discuss. Basically, hyperuricemia, next slide please, is a entity which has been known to us since long, and it has been described in very old literatures, like in before like even 1600 BC. So that it is not something which is new. It has been called podagra, and it has been known why it is there. Even in very when there is no modern medicine, it was known that there is uric acid which is there, and there are uric acid crystals which are formed because of it precipitates and forms uric acid crystals, which forms gout. So when there is a very high uric acid concentration, and when there is a clear-cut high uric acid which is causing symptoms like gout, there is no doubt whether it should be treated or not. It has to be treated. But with newer so many concepts which are there, that whether we should treat asymptomatic uric acid or not. So that is the current today's topic of my discussion, that if patient comes for a health checkup, and if the uric acid level is high, should we be treating this asymptomatic hyperuricemia or not? And that's why I thought we should discuss that, because those patients who are gout, those who have tophi, those who are having recurrent arthritis at any other part in the body, we have to treat it with uric acid lowering agents, uricosuric agents, and symptomatic treatment of gout. But when patients who are having uric acid which is asymptomatic, should it be treated or not? So the symptoms which can be, there will be intense joint pain, redness, tenderness of swelling. So these are the symptoms of gout. And it is usually caused by the deposition of the monosodium urate crystals in the joint. But in asymptomatic patients, it is usually because of the metabolic syndrome. Next slide. The uric acid is associated with chronic kidney disease. Like there is a relationship of serum uric acid level with increasing CKD stages. Like if the GFR falls, the CKD stages on increasing. There is a linear correlation. In CKD stage 1, there will be maybe if there are 20% of patients who are having hyperuricemia, if we see CKD stage 3, almost 40 to 50% of patients will have a high uric acid, and that is because of the reduced excretion. Hyperuricemia also may be induced, it itself also can induce kidney dysfunction. So whether it is a cause or an effect, it's always a dilemma, because the GFR has fallen and that is causing high uric acid, or it is the high uric acid which is causing drop in GFR. That is always a dilemma. And there is a formula which says that, like, if you have a GFR, like if you have a creatinine of 2 and the uric acid is proportionately around 7.5 or 8, then it is because of a low GFR, there is an accumulation of uric acid. But if a patient of a CKD stage 2 having a creatinine around 2.5 and has a uric acid of 10 or 11, then that is definitely, it is the hyperuricemia which is causing the renal dysfunction. So in that way, the disproportionate rise of uric acid will be able to give us some clue that whether it is because of the primary uric acid or it is because of the low GFR. And controlling hyperuricemia especially is achieved, if it is achieved early, may reduce the kidney disease risk. How does uric acid cause damage to the kidney? So there are multiple mechanisms by which hyperuricemia can contribute to the CKD progression. One, it reduces the nitric oxide bioavailability. So there is a reduced vasodilatation and renal ischemia. There is stimulation of the oxidative stress. There is activation of the renin-angiotensin system. It also causes systemic and systemic hypertension along with the glomerular hypertension. There will be vasculopathy in the kidney, and there is urate nephropathy, which is a very clear-cut entity where there is a deposition of the urates in the tubulointerstitium. And sometimes when patient comes with the mild proteinuria, unexplained renal failure, and if you do the biopsy, you tend to get this urate crystals in the interstitium. So this is called urate nephropathy, and it is very much treatable. In such patients, if you see the uric acid level may be around 7.58, but if you treat these patients and there is a significant improvement in the GFR, so we have to take each patient as a case by case and then decide whether this patient needs to be treated or not. Next slide. So when there is a hyperuricemia in patients with CKD, there are certain factors which lead to hyperuricemia. One, which is reduction in the GFR, which causes there is a accumulation of the uric acid because it is not filtered. Then certain diuretics like thiazide diuretics, which reduce the uric acid reabsorption, and because of that there is a hyperuricemia. If there is increased vascular resistance or there is associated metabolic syndrome like patient having insulin resistance, this is also one of the reasons why patient will develop hyperuricemia. How we diagnose the hyperuricemia and gout? So first is we have to do the blood test and see the uric acid in the blood. The other test is like presentation of gout. Patient presents with the typical symptoms of the metatarsal joint, mainly the toe joint of the first finger, first toe. It is typical, but there can be other joints also which can be involved. And from there, if we see the aspirate and check the crystals, there will be typical mono sodium urate crystals will be available, which can be seen in polarized light. Even in sonography, we get this typical sign of uric deposit. And there are certain signs of hyperuricemia, which like you can do is by there are certain genetic testing also, where patients who have a family history and in young age, if they have a uric acid, which is a very rare condition, if you do genetic testing also, you can know whether there is a hyperuricemia, which is a genetic cause or not. Other causes of very high uric acid is increased production, which is seen in patients who are having hemolytic malignancies or because of tumor lysis syndrome, which is seen after the chemotherapy. When there are a lot of cells which are breakdown at a very high level, there is an increased production which causes high uric acid production and which causes hyperuricemia. If we want to treat the patients of hyperuricemia, how to treat and when to treat. The studies have shown that there is a strong positive association between the serum urate levels and the chronic kidney disease risk. So whether we should treat these patients will depend on the GFR of the patient, and there is a target of uric acid which we have to achieve in patients who are having gout. Like if a patient has a gout, we should try to keep the uric acid below 6. But if the patient is otherwise having only metabolic syndrome and there is no symptoms of hyperuricemia other than uh, associated metabolic risk factors, then the target would be different. There are many studies which have been showing that if there is a high uric acid, there will be progression in the CKD. There is a study by October et al. Which was found that the chance of new onset CKD was almost double with serum uric acid between 7 to 8.9, and the risk rises 3 times if the uric acid level is more than 9. There are other studies like if patient has started on dialysis, and if we see most of these patients who are on dialysis, if we see uric acid, almost 50% of these patients have hyperuricemia. So it is a J-shaped relationship between the uric acid and CKD. Next slide. HSU et al. In a study of more than 175,000 patients, which were followed for 25 years, and they found that the elevated serum uric acid was an independent risk factor for the end-stage renal disease. Another study which was done, which was a longitudinal study which also demonstrated that the proportion of individuals with increasingly higher levels of hyperuricemia increases steadily as eGFR decreases. And moreover, the risk of progression to end-stage renal disease increases by 7% for each 1 milligram rise in uric acid. So in patients who are having CKD with stage of CKD in between 2 and 3, uric acid should be controlled, but other risk factors like obesity, hypertension, insulin resistance, so all other metabolic risk also we have to take into consideration when we decide to treat these patients. Although there are evidences of link between the increased serum uric acid and onset of CKD, there is a treating of asymptomatic hyperuricemia is not always indicated. There is a big controversy which is all the time going on whether we should treat this asymptomatic hyperuricemia or not. And so we have to consider multiple factors before we decide on to start, because it is not starting treatment which is important. It is the stopping of treatment becomes very difficult. So somebody once starts it, it is very difficult to stop by the other consultants. And there are always a side effect associated with any drug. Like if patient is on allopurinol, there is always a risk of hypersensitivity. Sometimes patient can have a severe Stevens-Johnson syndrome. In fact, few of the side effects of allopurinol, when there is a accumulation of oxalate, there is a deterioration of GFR because of the allopurinol itself. So, and in febuxostat, there is a black box warning that it can cause cardiac dysfunction. So, when we start a patient of hyperuricemia which is asymptomatic, we should think twice before we start. However, in patients with existing CKD, urate lowering therapy may possibly retard the progression. So if you have a CKD stage 2 and above, we should judiciously start it, monitor the patients well. We have to adjust the dose. Like if you have a CKD stage 2 and above, we have to adjust the dose both of allopurinol and febuxostat. Febuxostat needs significant dose reduction. Allopurinol requires significant dose reduction if you have a higher stages of CKD. If there is asymptomatic hyperuricemia, although uric lowering agents has shown evidence in slowing down the progression of CKD, there is still no clear clinical confirmation of the use of UTL in asymptomatic hyperuricemia. There is always a dilemma whether to use or not. More clinical trials are required to confirm the safety and efficacy, and several guidelines recommend starting urate lowering agents more than 9 after considering the risk and benefit ratio. And therapy for serum uric acid between 7 to 8.9 is only in the presence of renal stone or stage 3 CKD or worsening GFR. So there are certain guidelines when to start in CKD stage if the uric acid level is between 7 to 8.9. The uric acid lowering agents which are available are xanthine oxidase inhibitor. They remain still the first line of treatment as recommended by most of the guidelines. One is allopurinol and febuxostat. There is a newer molecule which is now available for the similar. It also blocks the xanthine oxidase, and it is called topiroxab. It is having a similar action. It also acts on the same chain of xanthine oxidase inhibitor, but it has a dual action. So it is more used in Japanese, and there are a lot of Japanese data which is available. Topiroxamide in India, it is now recently available, and it has another action other than xanthine oxidase inhibitor, and it is a little more potent as compared to febuxostat. That is what is the claim, but once we start using it, then only we will have more idea about the efficacy and safety of that particular molecule. Allopurinol reduces serum, and uric acid within 24 hours and may have effect for up to 2 weeks. The doses are 300 to 400 milligram. Adverse side effects are skin rash, hepatotoxicity, Steven-Johnson syndrome, and blood dysplasia. Febuxostat, it reduces uric acid faster within 24 hours. The dose is 40 to 80 milligram, and adverse side effects are similar: hypersensitivity reaction, altered LFTs, and tubulointerstitial nephritis. Febuxostat is a metabolized in liver, and it has a better uric acid reduction as compared to allopurinol. There are 2-3 studies which are available which show that it has a better lowering of uric acid as compared to the allopurinol, lesser side effect, and it is more potent as compared to the allopurinol. And the most important thing is dose adjustment is not required in febuxostat as compared to allopurinol in patients who are having renal dysfunction. The only thing which we have to worry about is the cardiotoxicity, which has been seen in few of the trials. And but of course, there are few trials which were then published afterwards that they negated this, and it is not that cardiotoxic, but can show QT prolongation. And when we start this molecule, we have to monitor these things and keep a watch on QT. Febuxostat is developed to address the cardiotoxicity caused. There is a which is phase 1 study which demonstrated that reduced and more stable exposure to febuxostat with extended release tablets compared to the early release. So extended release tablets can have less cardiotoxicity. So to summarize, although there are conflicting evidences of treating asymptomatic hyperuricemia, positive benefits in renoprotection and slowing down the progression has been noticed in existing CKD. There are so many studies now coming up that it has some benefit of keeping uric acid under control in asymptomatic hyperuricemia and retarding the progress of CKD. Target uric acid in patients on therapy for asymptomatic hyperuricemia is less than 6. Administration of febuxostat or allopurinol or topiramate, they which are all xanthine oxidase inhibitor, that all results in a prompt and persistent reduction in the serum urate concentration. However, xanthine oxidase inhibitor treatment in hyperuricemia must be considered with caution, considering the adverse side effect. And febuxostat is a promising xanthine oxidase inhibitor. However, more trials are required. There are certain other newer molecules which are available, which are uricase inhibitor. These uricase is the enzyme which converts the uric acid into the allantoin, which is the main important molecule which is excreted easily. It is water soluble, and this is what in birds and other primates it is easily excreted, and there is no hyperuricemia in this because they have this enzyme uricase. And now uricase has been produced and it is called rasburicase. So in patients who are having severe hyperuricemia, who are sensitive to xanthine oxidase inhibitor, or when we are expecting a very high uric acid like tumor lysis syndrome, we can give this molecule, which is uricase inhibitor. It is available with the name rasburicase. And now pegylated rasburicase is available, which is called pegylated rasburicase, which is longer acting and safer. But all these are expensive compared to the oral medications. And now IL-1 inhibitors are also available, which is a very, very new molecule, which is very, very effective in reducing the uric acid, but still not available in India. Thank you.
Thank you so much, ma'am. There is one question from the audience regarding the irregular pattern of the gout flares in the CKD patients. So if there are complaints of gout flares in the patient, but however it is shown asymptomatic at that moment, so do you suggest the treatment for such patients?
If patient has a gout, documented gout in past, and presently if it is he's asymptomatic, but if he has associated CKD also, it is always better to target his uric acid below 6. Though he's asymptomatic now, we should target his because these patients will be able to give meds. They may require colchicine. It also has some amount of side effects and renal impairment, and then we are left with only steroids. So it is also better to prevent the gouty attacks in patients who are having CKD or renal impairment and target the uric acid below 6.
Okay, ma'am. Ma'am, there is another question regarding the treatment with the corticosteroids. Do you recommend corticosteroids in the management of gout flares?
When patient presents with acute gouty attack, there are 3 options which are available. One is NSAIDs, which is most effective non-steroidal anti-inflammatory drugs. The second choice, which is colchicine, and third choice is steroid. Sometimes giving steroid locally into the joint, intra-articular steroid, is also very effective, but I would not recommend it is as a first line. If patient has a contraindication to the first 2, then yes, steroid can be given. Or if patient doesn't respond to the first 2 line, then we can consider.
Shantanu sir, are there any more questions?
Yeah, I have one question. Does, ma'am, any Indian data is there about the uricemic patient? They will be having this CKD complication. Any data has been published till date?
The data, there are a lot of papers which are there, which is like CKD and uric acid comparison. But particularly Indian data, exactly which I have no idea. But there are many data which is now coming up because there is a lot of controversy whether we should treat this uric acid or not. Because whether it is a cause or effect, we don't know. But definitely there are, when we are treating CKD, there are new armamentarium to retard the progression of CKD. One of them is to reduce uric acid. So a lot of data coming up.
Oh, okay, ma'am. Thank you.
Ma'am, there is another last question from the audience which has come up now. So basically, when it compares to allopurinol and febuxostat, there is a lot of data coming up regarding, febuxostat being safer and efficacious. What is your take on these particular molecules and what would be your approach, ma'am?
Yes, definitely. Febuxostat is more well tolerated as compared to the allopurinol. It is more effective as compared to allopurinol, and dose, particularly in patients with CKD, the dose modification is not required. So it is better than allopurinol. That's my personal this thing. There is no clear-cut study, but there are few studies which have definitely shown that it is more effective. I show you on my slides that there are studies which show that febuxostat is little more potent and more effective and less side effect. And CKD patients digest.
Okay, ma'am.
Ma'am, just one question. Do these drugs have any renal protective effect? What are the drugs we are using in the gout treatment, ma'am?
Indirectly by reducing the uric acid, yes. Directly by drug itself, not much, except for there is some free radical mechanism which has been postulated, but it is not 100% clear.
Okay, ma'am.
Okay, ma'am. If there are no further questions, we can end the session. Shantanu sir, there are no further questions, right?
No questions.
Okay. So with this, I would like to express a vote of thanks to Dr. Sonal Dalal, who has joined us today evening in spite of a very busy schedule. Thank you so much, ma'am, for your very comprehensive and an insightful talk on hyperuricemia. I am sure the audience watching, all the physicians, diabetologists who have joined us today will gain insights through this. And we look forward to your guidance and support in the further initiatives that we take ahead. And I would also like to thank all the doctors, the delegates who have joined us today. We look forward to your feedback on these sessions, and we would like to address further questions also if there are any. We will take it up after the session with ma'am. Thank you so much. And lastly, I would like to thank our team for wonderful execution of this NEFFRON session. Thank you so much.
Thank you. Good night.
Good night, ma'am.